Welcome to the podcast whimsy that is the Persiflager's Puscast, a review of the infectious disease literature with snarky commentary for the last 2 weeks of August 2009. Remember, you can skip this intro and you won't have to listen to me whine about the 2.5 days I pissed away installing Snow Leopard on my Mac. My first time I've been disappointed by Apple. This is on iTunes, and as always, I beg you to feed my ravenous ego by writing me glowing reviews on iTunes. This is brought to you by Pusware LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion, your uber-hyperlinked electronic guide to infectious diseases at pusware.com. This is CME accredited. After you've listened, take the online quiz and get a half an hour of free CME thanks to Legacy Health System. Because it's CME accredited, I must mention my conflicts of interest. I ain't got none. But my honor and integrity are for sale. Please inquire. Also, don't forget my Quackcast, a review of supplements complementary and alternative medicine, i.e. scams. My infectious disease blog over at Medscape, Rubor, Dolor, Calor, Tumor. My occasional participation in the science-based medicine blog at sciencebasedmedicine.org. My podcast of my Rubor, Dolor, Calor, Tumor blog is now a Gobbet Opus, also available on iTunes. So many opportunities to participate in the Mark Crislip multimedia empire. 2 blogs, 3 podcasts, and an online infectious disease guide. Because indeed the world does need more Mark Crislip. And now, on to the literature. One of the things I'm always saying is, Jeff, mow the lawn. And then an hour later, didn't I tell you to mow the lawn? And then an hour later, the lawn's still unmowed. Now I know why he's hesitant to mow the lawn, thanks to a study out of Australia entitled Infections Following Lawnmower and Farm Machine-Related Injuries in Children. It turns out that they looked at 24 patients who were admitted with lawnmower injuries, and 17% of them had infections. There was a mixed group, and it included everything from gram-positives to gram-negatives, including a case of osteomyelitis due to Stenotrophomonas multifilia, and another one due to Cedosporium prolificans. The age distribution was bimodal. There was a 2 to 4-year-old group, and then there was another peak at 14 years old. The first are kids who are too stupid to stay away from the lawnmowers. The second is a teenager who's probably too concerned with what's going on with the music of his iPod or texting to pay attention and gets a lawnmower injury. I shouldn't laugh. But now when my son doesn't get the lawn mowed, I'll just know he's trying to avoid infections. We're heading into what may potentially be a particularly nasty influenza season worldwide. China and Australia have just started producing their vaccine, and Japan hasn't started yet at all. So the fact that we're getting some vaccine in mid-October shows at least we're going to be ahead of the curve. You're going to have, hopefully, a slow season, but I would not be optimistic, and patients will be admitted with influenza to your hospital. How long will they be secreting influenza in their respiratory secretions? The study was published in the Journal of Infectious Diseases this month. It looked at viral loads and duration of viral shedding in patients with influenza. They had 147 patients with influenza A, and they did daily swabs and did PCR looking for viral RNA concentrations. They found, not unsurprisingly, the sicker you were, the higher the viral load, and the patients were able to have detectable influenza virus up to 7 days, although there was a nonlinear clearance of influenza. Patients with comorbidities and patients on systemic steroids were, not unsurprisingly, slower at clearing the viral RNA from their swabs. Also of interest that oseltamivir was effective up to 4 days after starting their symptoms for influenza, and did lead to a more rapid decline in the RNA clearance by PCR. So it may be benefit to give oseltamivir up to 4 days after the onset of symptoms for influenza, but it does emphasize the importance of making the diagnosis sooner rather than later. I'm back. Onward. So what you going to do to avoid the flu? I, for one, plan on charging $5,000 for a Tamiflu prescription. But the way these things are spread is by the respiratory route. Now, we all know that coughing is a good way to generate droplets that can spread respiratory viruses. But are there other ways that can do this? The study looked at a bunch of college students, and they used masks to collect aerosols generated first by coughing, then by talking, and then by quiet breathing. They also got nasal mucus samples. God, that must have been fun to do. And most of these patients had cold symptoms. However, they found that just in quiet talking, which I've never done, of course, I'm a loud talker, but just quiet talking is enough to generate positive specimens for rhinovirus, so that if you're just standing there talking to somebody, they could be giving you the deadly flu. So your best bet is what I like to call the Bill Clinton technique. Don't inhale. Worked for him, works for me, plus I look good in blue. The young whippersnappers in the audience may not remember a disease called AIDS. We used to see it all the time back in the time before fairly active antiretroviral therapy, or FART as it is called. One of the complications that we used to see was spontaneous pneumothorax, which is not an uncommon complication of HIV disease. This study looked at the etiology of spontaneous pneumothorax in patients with HIV disease. This was done in Spain, where the pneumothorax in Spain falls mainly on the plain. They actually had a whopping 1% of their patients develop spontaneous pneumothorax, which is pretty amazing. There were 3 big causes. Bacterial pneumonia, which tended to occur in drug users, and pneumocystis was the most likely cause in men who have sex with men or in people that have bilateral pneumothoraces. This also tended to correlate with lower CD4 counts, not unsurprisingly. And occasionally there was the odd case of tuberculosis. But spontaneous pneumothorax can also be a son of a gun in this patient population to heal, and that low CD4 count patients often, in the old days, did not seal their leaks and could have chest tubes for prolonged periods of time. In this area of highly active antiretroviral therapy, you all probably don't see pneumocystis, much less spontaneous pneumothorax. But HIV disease isn't the differential of somebody that pops their lung. I'm back. You probably didn't miss me, but I went for my daily walk. Then I came back and had taco pizza. Really, is there anything that's not better as a pizza? One of these days I'm going to have a peanut butter and jelly pizza. So let's move on. Now we're going to talk about rickettsia. Now there is an organism called Rickettsia senetsu, which is supposedly comes from eating raw fish. It causes, from this abstract, quote, a largely forgotten infectious mononucleosis-like disease, and they wondered if it indeed comes from fish. So they took a bunch of patients who had an undifferentiated febrile illness and looked by PCR for the presence of Rickettsia senetsu, and they found indeed that patients had it. Interestingly, they then found it in a fish. So the theory that this comes from eating raw fish in Laos may be true. They looked in these patients on the buffy coat and found it. Whether they did it on the angel coat or the willow coat is unknown. But if you have someone who's eaten raw fish after travel to Southeast Asia and they have an uncertain febrile illness, consider neorickettsia illnesses. And also remember that Buffy the Vampire Slayer was the best television show ever. Pertussis, or whooping cough, is a nasty disease. And if you go to the YouTubes, you can find some videos of kids trying to whoop themselves to death with whooping cough. It's pretty hideous. However, we have a vaccine. So most kids, if they get the vaccine at least, are immune to pertussis. The problem is that adults and adolescents are probably a reservoir for disease as immunity fades with time. And there's an ongoing problem with outbreaks in hospitals where an adult will become positive pertussis and spread it in the hospital to children and then back then to adults and perpetuate it through the hospital. Pertussis is a royal pain in the patoot if you do infection control for a living. The patoot, by the way, is that little area under your chin next to the wattle. This study, which is just of interest, is how good is the vaccine for getting an immune response in an adult. Currently, there's now a tetanus, diphtheria, pertussis vaccine, the DTP, or probably the TDB, or the LSMFT, for those of you who are really old. And adults, when they get their trauma and go in for a tetanus vaccine, should get the tetanus, diphtheria, pertussis vaccine. They looked at the kinetics of the vaccine in adults who had it during an outbreak and found that by 2 weeks after the vaccination, roughly 90% had protective antibody. So if you're worried and you're having an outbreak in your hospital for pertussis, and you're going to have one, you may not have found it, but if you have kids in your hospital or you have anybody wandering around with a cough, you're going to get a pertussis outbreak. The way to decrease that is to get everybody, especially adults, vaccinated with pertussis, and you'll get a rapid response to the vaccine if you're in an outbreak situation. And I guess the emergency rooms in Baltimore, or as they call it, Baltimore, have a different vernacular than we do here on the West Coast. This article out of the University of Maryland School of Medicine is entitled Evidence Against the, quote, Booty Pack, unquote. Trichomonas not associated with gonorrhea or chlamydia. I'd not heard of the term booty pack. And in fact, if you Google the term booty pack, it's only this article. So I guess in Baltimore, they call multiple infections a booty pack. The question is how many STDs are associated with each other. The rule is always if you treat chlamydia, treat gonorrhea. If you treat gonorrhea, treat chlamydia. Is this true of trichomonas as well? And they looked at patients, 795 eligible females, of whom 105 had trichomonas, 74 had chlamydia, and 35 had gonorrhea. And they found that gonorrhea and chlamydia were strongly associated with each other, but trichomonas was not. Therefore, the presence of trick did not mean they needed to be treated necessarily for gonorrhea or chlamydia, hence the term, I suppose, booty pack. I don't use that term on the West Coast, but I think I'm going to start using it. Booty pack. If your institution does use the term booty pack, drop me an email at mcrislip@mac.com. I would be curious about the current vernacular since I'm a 52-year-old man and I'm hardly with it with the talking of you youngsters. Booty pack. Oh, God, let's move on. We, the royal we have talked in past podcasts about the importance of timed positivity in helping to determine whether or not the bacteremia in a patient is significant or real. With Staph aureus, if it's less than 24 hours, it's important and probably represents an endovascular infection. With Canada, it's probably closer to 36 hours. How's about the old coag-negative staph? This study looked at both time to positivity and quantitative blood cultures and found that if your time to positivity was less than or equal to 16 hours, you were having a high-grade bacteremia from probably a central line. So not only is it true for Staph aureus, but also for coag-negative. If in your blood culture is positive in less than 24 hours, you probably have a high-grade bacteremia, and at least for coag-negative staph, that central line is probably the source. And interestingly, we're more likely with a 50-50% chance of having the central catheter removed. As we push ahead with vancomycin to higher and higher trough levels to try and kill off MRSA, which has higher and higher MICs to vancomycin, are we going to see toxicities from this? For years, it's been maintained that by itself, vancomycin is neither ototoxic nor nephrotoxic, but that's when we dosed it with troughs of 5 or 10. Studies have shown recently that if you're older and you have higher troughs, you do get ototoxicity, older being greater than 55. This study in the Clinics of Infectious Diseases this month looked at this issue of nephrotoxicity in patients with no other reasons for nephrotoxicity but being on vancomycin, and found that the higher the trough level, especially when the concentrations were greater than 20, there was an increased risk of nephrotoxicity. So we are going up a creek without a paddle, and that by itself, at higher levels, vancomycin is oto and nephrotoxic, and that if we try and push this drug, we may get unacceptable nephrotoxicities. The downside is the other drugs we have are no better. So pick your poison. A couple of podcasts ago, I talked about a clinical infectious disease study that showed that honey is able to inhibit Staph aureus and Pseudomonas, amongst other bacteria. This little study looked at the susceptibility of Campylobacter species, specifically Jejunii and coli, against honey, and they found the Campylobacter was inhibited by 1% honey. This is a specific kind of honey that they love to use, Manuka honey. That is from New Zealand and is a specific type of honey that they're trying to get for medical use. So they're suggesting that if you could chug-a-lug enough honey, besides dying of hyperglycemic coma, that you might be able to take care of your Campylobacter infection. I'm sure this will be bandied about in the quack literature. I think it's interesting and fundamentally unimportant unless you happen to have Campylobacter in your wound. Another one of my favorite type of studies, a Bon Appetit study. They went to Nairobi, Kenya, and they went to tourist hotels, and they found 885 food handlers. And they checked their stools to see if they had anything that was pathogenic. And they found of the 885 food handlers, 39 or 4.5% had some sort of pathogenic E. coli in their stool, and they were often more likely to have loose stools. So when you go to Nairobi or any other third world country where people are handling your food, they're probably giving you E. coli at the same time. You don't necessarily have to drink the water to get turista. Life is never quite as simple as one would like. And this is especially true in the asymptomatic bacteria in the diabetic woman. Does treating make a difference in infections? And does it make a difference in the strains they carry? This study out of Canada, looked at 105 women with diabetes, and they were followed for 3 years and had urine cultures done. And they looked at the strains of the E. coli in their urine. They found that patients were likely to carry the same strain for up to 6 months at a time. But if you treated them, although the E. coli would go away, they would get reinfected, but instead they would get a new strain. In this study, at least, treating patients for their asymptomatic bacteria only led them to getting a new infection with a new strain of E. coli, but did not overall decrease the rates of urinary tract infections. And this was in patients who were at risk from neurogenic bladder or not. So having underlying mechanical issues didn't make a difference in this particular population, which also goes against the standard dogma of the diabetic bladder. So like all good clinical studies, it raises more questions than it answers. Back in my first or second year of practice, I saw this young lady. She'd spent a month in Southeast Asia, having unprotected sex, drinking the water, eating the food, shooting heroin. Then she went to India, where she had unprotected sex, ate the food, drank the water, swam the Ganges, and then in a fit of guilt, I suppose, she spent her last 2 weeks in India in Calcutta helping bury the dead at Mother Teresa's. Mother Teresa had a lot of dead, believe me. Don't get me started on her. Anyway, she came back to the United States and she had fevers. What were her fevers from? Well, it was typhoid fever, Salmonella typhi. And there's a recent review in JAMA of cases of typhoid fever in the United States and where they came from. And of the cases, the vast majority have come from India, Pakistan, and Bangladesh, 80% of the cases. So over 2/3 of the cases of the people who get typhoid fever have come from that part of the world. The other interesting thing about this particular study is that 95% of them had not had the vaccine. And the other thing about Salmonella typhi is resistance to antibiotics. They're usually resistant to chloramphenicol, ampicillin, and TMP sulfa. In this study, 13%, which is not usually, but still a significant number. And 97% of them had decreased susceptibility to ciprofloxacin. We've talked in other podcasts how third-generation cephalosporins are probably the treatment of choice right now for Salmonella typhi, pending the results of the cultures. So when you go to India and you feel guilty and start burying the dead, don't eat and drink the water. Time for a little sepsis hodgepodge. There are a bunch of articles about sepsis this year, just little fine points that are of no surprise, but worth emphasizing for people who take care of patients for a living. One study, which published in the American Journal of Respiratory Critical Care Medicine, nice long journal, looked at what was associated with the effectiveness of treatments for severe sepsis. They found two interventions were associated with improved outcomes. One was the use of dodrecogen alpha, i.e. Zygris, but more importantly and more practically, the early institution of antibiotics. And then what got antibiotics in less than an hour after the diagnosis of sepsis did better than those who had greater than 6 hours. So if you have a patient who's going septic, don't go down to the cafeteria for a bite to eat before starting the patient's antibiotics. I used to say, never miss a meal for a patient. Now I'm not so sure that's true. Another article, which was published in the journal Chest, looked at the initiation of inappropriate antimicrobial therapy. And if you have patients in septic shock and you gave antibiotics to which the organism was not susceptible, you had a 5-fold decrease in survival. So picking your antibiotics correctly up front really does make a difference, and that's been shown in multiple studies. And finally, sex makes a difference in your outcomes in sepsis. No, I'm not talking having sex while you're septic, but your gender. And female gender is associated with increased risk of intensive care mortality in a study that was published in Critical Care Medicine in September. So the take-home is you don't want to be a female who gets late, inappropriate antibiotics when you're septic. You want to be a male who gets appropriate antibiotics within the hour. Osteomyelitis of the jaw is not the same as other myelitises, in that it often can be treated with oral antibiotic. But the question is, what oral antibiotic? This study looked at the microbiology of 46 patients with osteomyelitis of the jaw. They found that most often the etiology was due to viridin strep, which is not unsurprising, but which should not surprise anybody who is an infectious disease doctor at least, was resistance to clindamycin. 11.5% of the viridin strep in this study were resistant to clindamycin, and often this was due to prior antibiotic exposure. However, across the board, upper respiratory viridin streptococci are becoming increasingly resistant to clindamycin, and the same is true of anaerobes as well. Bacteroides and their cousins are often resistant to clindamycin. I think this is yet another nail in the coffin of clindamycin for the treatment of above-the-diaphragm infections of all sorts, be it lung abscess, empyemas, or dental abscesses, especially if you do not know the susceptibility. One of those little factoids I have in my head is that resistance is costly to organisms, and generally speaking, they are less fit, at least in terms of multiplication, and as a result, perhaps in transmission. Well, of course, that's a simplistic way of thinking about things, and every time I open my mouth about evolution, somebody calls me a moron. Well, this study looked at the epidemiologic fitness cost of drug resistance in Mycobacterium tuberculosis. They had a mathematical model, but they included in it molecular epidemiology from Cuba, as my grandmother used to call it. She was from Massachusetts, Estonia, and Venezuela, as she used to call it. It's actually Cuba and Venezuela. And they found that drug resistance did not give much cost for transmission and only decreased it about 10%. And They also found that, judging from the epidemiologic data in these countries, that sensitive strains are as fit as resistant strains. So that acquiring antibiotic costs was not a detriment to the organism's transmission. This is kind of a bummer because resistant tuberculosis is increasing in the world right now, and I had always hoped, probably inappropriately, that they were less transmissible. No such luck. So be it flu season or tuberculosis season, the Bill Clinton technique of not inhaling is still your best bet. I have ranted on this topic before, but there are a few things that irritate me more than reading an article about an unusual or very rare infection, and then the author says something like, "One needs a high index of suspicion in such cases." No, you need to have a low index of suspicion for unusual cases, and weird stuff happens, and there's not much you can do about it. I think I may have an exception to that, however, which is tuberculosis. And this study, which was published in the American Journal of Respiratory Critical Care Medicine, looked at the proportion of tuberculosis versus advanced pulmonary tuberculosis at the time of diagnosis. The longer you have tuberculosis, the more likely you are to progress to advanced tuberculosis. So what's happened in the United States for the last decade is that the percentage of cases of advanced tuberculosis have been decreasing relative to the cases of pulmonary tuberculosis. This implies a delay in the diagnosis of tuberculosis. And part of the problem with TB right now, of course, is that it is on the decline with its incidence. Fortunately, we are heading into an economic letdown and a decline in the funding of public health, so one can hope as a result that tuberculosis will start increasing again. People will be making the diagnosis sooner, and as a result, fewer people will have a delay in diagnosis. So you see, you need to look on the bright side of economic downturns. They're good for infectious diseases. Of course, no one will have insurance to pay for their consultation, but at least they'll be sick, and that's something. Two things for yeast, just more for entertainment's sake. One was a study that looked at the virulence of the new strain of Cryptococcus found in the Pacific Northwest, Cryptococcus gotti, named, of course, after John Gotti, the mob boss of New York City. It turns out that the reason, amongst other things, that this organism is more virulent is it is able to survive in macrophages or macrophages, whichever one it likes to survive in them, and this is part of what's linked to its virulence. They also found that it has a lot of upregulated mitochondrial genes, but I don't know what the hell to make of that. The other thing is that just came out this month in Nature is that Candida albicans has sex. As the abstract said, until recently, Candida albicans was thought to be strictly asexual, i.e. married. Now it turns out that Candida can have both heterothallic mating and homothallic mating. Yeasts, for mating purposes, can occur in two types. If the same type mate, it's homothallic. If different types mate, they're heterothallic. It turns out Candida has both. I wonder if James Dobson is going to protest the homothallic mating found in Canada. It's obviously part of the homothallic lifestyle agenda that's part of the Democratic Party that will turn all of our yeasts into homothallic maters. A fun case of malaria out of Paris. This couple who was living together both came down with malaria. Neither of them had ever left France, and France is malaria-free. They looked at the infecting organism and found them to be identical in both patients genetically. And history of travel showed they'd been traveling around France and stayed near Charles de Gaulle Airport. The presumption is that an infected mosquito came into France by way of Air France, and that the mosquito bit one person, got their feeding interrupted, went on and bit the other person, and gave them both malaria, since malaria is not a sexually transmitted disease. So they presume, because of the genetic identicalness of the malaria, one mosquito, 2 bites, 2 cases of malaria. And they happened simultaneously, so one would presume that they got bit at the same time. They, however, failed to address another reasonable hypothesis in that one of the couple is actually a vampire. If you ask me, in movies like Twilight and TV shows like Buffy, best show ever, insufficient attention is paid to vampirism as a potential spread for malaria. The real take-home message is malaria can occur in anybody, and it's a mosquito hopping on an airplane, sometimes referred to as suitcase malaria, that can occasionally cause a case of this disease in people who have never visited an endemic area. I think the CDC site has 50 cases of malaria in the United States and people that have never left the United States. Like all vector-borne infections, just because you don't go to where the infection is doesn't mean the infection can't come home to you. And now comes that bi-monthly time of sadness, the end of the Persiflager's Puscast. You'll have to wait another 2 weeks for the next one. This has been the Persiflager's Puscast for the last 2 weeks of August 2009, a review of the infectious disease literature with commentary. References, of course, are on the website, pusware.com. CME accredited. Now that you've listened, take the online quiz and get a half an hour of free CME, thanks to Legacy Health System. Brought to you, as always, by Pusware LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion. And don't forget my worldwide multimedia empire. Rupert Murdoch better watch his ass. There's the Quackcast, the Puscast, the Gobbet O Puscast, the Science-Based Medicine blog, and Rubor Dolor Kalor 2 more, my blog over at Medscape. Because the world needs more. Mark Crislip. Unfortunately, Cash for Clunkers does not apply to this podcast, although I did get a nice Volkswagen recently because of Cash for Clunkers. So feel free to support this podcast by sending me a few dollars, as my son used to pronounce it, or buy me a beer in Philadelphia this year at the national meetings. Otherwise, this is copyright 2009 in the Creative Commons license, and the music is by my son when he was 12 years old, improvising on the guitar. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most interesting case. I will continue to follow along with you. Thank you. In dictation, goodbye.